Okay, hello friends, welcome back to my channel Medicine Upon Zero, and today we'll talk about one of the most important topic regarding endocrinology, that is the hypothyroidism. Okay, so when you are talking in terms of the hypothyroidism, basically from the term it's quite easy to understand. There will be reductions in the what? Reduction in the productions of T3 and T4 level. Okay. Now see, when you are talking in terms of the hypothyroidism, so you have to classify the hypothyroidism in the two ways. It may be the primary hypothyroidism, it may be the secondary hypothyroidism. Okay. Now let's classify first. So I'm writing it over here. Hypothyroidism. Hypothyroidism. Now it can be classified into two ways. One, we can get the primary hypothyroidisms. Another, we can get the secondary hypothyroidisms. How can we just differentiate them? Now see, if we see any kind of the problem in the gland level, within the thyroid gland, okay, for example, for whatever the reasons, if we see the problem where at the gland level here within the thyroid gland, at that time if you see the productions of the T3 and T4 that is getting decreased, this type of problem that will be known as what? This will be known as primary hypothyroidism. So see, whenever T3 and T4 that will be less, so definitely within the circulations, if we see within the circulations, what the T3 and T4 that will be also less. So whenever we get within the circulations T3 and T4 that is less also, at that time, the signal that will be sent where within the hypothalamus, from hypothalamus the same, the signal that will reach where within the anterior pituitary, and from anterior pituitary we will see the releasing of what? The TSH hormone. From the anterior pituitary we will get the releasing of the TSH hormone. Here we will get the TRH, we will get the signals over here, and from here we will get the TSH. Now see here, whenever we are getting the less amount of the T3 and T4, okay, by the what type of the thing we'll see over here, see, the T3 and T4 is less, at that time, these things, the signal that will just, they will realize over here that definitely the T3 and T4 less. So what do you know, the TSH from here, it will be released. After that, it will come over here and it will stimulate the what? These thyroid cells over here, the follicular cells, and they will stimulate to release the what? T3, more amount of the T3 and T4. So one thing we can get over here, if we get the problem at thyroid gland level, this type of the problem that will be known as primary hypothyroidism. Okay. Now for that thing T3 and T4 that will be less, but the TSH level that will be increased over here. Okay. So try to understand from here. In this case, what we are getting in the primary hypothyroidism, where at the level of thyroid gland, we'll get where at the thyroid gland. In this case, if we see any kind of the dysfunctions within the thyroid gland or any kind of the problem, at that time we'll get the T3 that will be less, the T4 that will be also less, and whatever the TSH, definitely the TSH that will be activated. Okay. The feedback inhibitions, positive feedback, negative feedback from hormonal things, these are the basic things. Okay. Now what about secondary hypothyroidism? If we get, try to understand, if we get any kind of the problem within the pituitary, for example, we are getting not the problem at the time the thyroid gland is okay, there is no problem within the thyroid gland, but the problem arises right now where within the anterior pituitary, from where the TSH will come. If we get any kind of the problem where in these positions, for as a result, if we don't get the TSH secreted from these portions, so TSH that will be less, definitely TSH will be less. So whenever less amount of the TSH will come over here and less activations will get over here. Try to understand, whenever the less TSH, for the damage of the pituitary, the less TSH produced from the pituitary, so the less amount of the TSH that will activate, less will get the less activations where within thyroid gland. So as a result, we will get the less amount of T3 and T4 also. So if we just write it over here in terms of the secondary, hypothyroidism, here we will get the problem at the pituitary level. Okay, here we will get what? The T3 that will be also less, the T4 that will be also less, and whatever TSH will be also less. Okay, but in some cases we can see the T3 and T4 that is less, whereas the TSH level is normal. For example, okay, whatever the TSH released from here, that is inactive, that is biologically inactive. For example, if you write it over here, it is biologically inactive. Definitely whatever the TSH, for example, the quantity that is enough, but the quality is not good. So if you don't get the good quality, or the dysfunctional TSH over here, so they will be not able to stimulate the thyroid cells or the follicular cells to release the T3 and T4. So sometimes we can also see when the the T3 and T4 less, but the TSH level is normal, but it is biologically inactive. Sometimes we can write it over here. Sometimes we can get a T3 that is less, T4 that is also less, but we can get the TSH that is normal. In these cases we can get. Now I'll tell you about the etiologies. What type of etiologies we can get in the development of the primary hypothyroidism and the secondary hypothyroidism. When we are talking in terms of the primary hypothyroidism, for example, the most common one what? Iodine deficiency disorder. So if we get iodine, deficiency disorder. So if anybody takes less iodine containing salt or he is having iodine deficiency, at that time what do you know? To produce the T3 and T4, definitely I have already explained in the physiology of the thyroid hormone that we will get the attachments of the this iodine molecule where along with the tyrosine molecules, tyrosine amino acid that is present within the thyroglobulin molecule. After the attachment we will get the coupling reactions, then we will get the productions of the T3 and T4. But if you don't get the iodine over here, try to understand from these portions. If we don't get the iodine, definitely the T3 and T4 that will be also less, the first reasons. Now another thing, for example, any mothers, okay, during pregnancy time, if we check the TSH level or the thyroid hormone level that is less where within the mother at the time. So see, whenever let's write straight over here, whenever the mothers, for example, the mothers is having less T3 and T4, the same way from the mother through the placenta within the baby or the fetus, whatever you can see over here, the less amount of the T3 and T4 that will reach over here. Okay, whenever we will get the less amount of the T3 and T4, as a result, different kinds of the problem will get over here. Whatever the problem, we'll get the mental retardations, the physical growth that will be not developed properly. We'll get what? The mental retardations, because the thyroid hormone that is responsible for maturing the mental mental maturations, we can say, along with the physical development. But when you are talking that mother is already hypothyroidism, the mother is having hypothyroidism. At the time, the baby or the neonates, or you can say the fetus, that will have less amount of the T3 and T4. As a result, will get not the proper mental retardation. Will get the mental retardations. Will not get the proper physical development. Now these things, in another way, you can say over here, there is the congenital hypothyroidism. Now let's have some words about the congenital hypothyroidism. Now where we can see the congenital hypothyroidism. Now, for example, if we write it over here, the congenital hypothyroidism. Now, congenital hypothyroidism, we can get the 3 levels. For example, okay, thyroid. For example, if we get the problem at the thyroid level, that means the thyroid gland of the fetus or the baby over here that is not functioning. So let's use a different color and different term for it. Okay. Thyroid dysgenesis. If we get thyroid dysgenesis at the level where the problem is where? The problem is at the gland level. The next thing we can get it over here. Thyroid, dysharmoniogenesis. Here we'll get the problem will be where at the T3 and T4 level. Here the problem where at the here the organ is okay, here the gland is okay, but the gland is not able to produce the enough amount of the T3 and T4. Here the organ, the gland, that means the thyroid gland is not okay in the first region, thyroid dysgenesis. The second region, thyroid dysharmoniogenesis, or you can say endemic goiter, or you can say endemic. Okay, let's use the different color for it. We'll write the different name for it. Cretinogens for the babies we can use. Endemic cretinogens, sorry. So we can endemic cretinism. We can get the endemic cretinogens in terms of the what pregnant. So and if they are having the less amount of the T3 and T4, the less amount of the T3 and T4 that will be delivered to the fetus. As a result, we can see. So if the question is asked, what is the reason for developing the within the neonates the hypothyroidism? Definitely, we are not going to see the iodine deficiency. We are supposed to say that what the thyroid dysgenesis, or we can say the mothers in terms of the mothers. Okay, in terms of the mothers, the mother was having hypothyroidism. As a result, the neonates of the fetus developed the also same kind of the thing over here. Okay, now these are the causes. Now First, I did talk about the iodine deficiency disorder. Second, whatever the problem you can see over here, try to understand. In females, we can get what? Autoantibodies against the what? Thyroid cells. Autoantibodies against the thyroid glandular cells. So here this is known as what? Hashimoto disease. You can get the Hashimoto disease, where we will get the autoantibody against the follicular cells. In this case, you see, whenever the follicular cells or the thyroid cells, they will be destroyed. Whenever we get the productions of the autoantibodies, so against the thyroid follicular cells, at the time the cells are getting destroyed, so definitely they will be not able to produce the T3 and T4. So this kind of the problem you can see also over there. And the third, for example, there are some certain kinds of the foods, for example, the cabbage. Okay, certain kinds of the food, for example, the cabbage. This cabbage where this inhibits in organifications of the iodine in organifications along with the iodine with the tyrosine molecules. So food, for example, the cabbage, that will inhibit in the organifications in thyroid hormone productions. So inhibit where in organification. So whenever we get the problem at the level of the organifications, definitely the productions of the T3 and T4 will be less. And if we say as far as the drug is concerned, there is a drug that can cause also the what? Hypothyroidism, that is known as what? Amiodarone. Anti-amiodarone. So amiodarone, that can cause both. It can cause the hypothyroidism, it can also cause the hypothyroidism both. Now let's talk about the in terms of the secondary hypothyroidisms. Now, in terms of the secondary hypothyroidism, what can we see over here? Let's talk. You will definitely will get the problem at the pituitary level. We have to get the problem at the pituitary level. So, what are the problem we'll get first? We can talk about here the Sheehan syndrome. Okay, let's use different color and the different portions. Okay, let's use this one. So, first we'll get the Sheehan syndrome. So what do we know in terms of the Sheehan syndrome? We'll get the postpartum, hemorrhage within the anterior pituitary. If we get the postpartum or hemorrhage within the anterior pituitary, then you can get the Sheehan syndrome. In terms of the Sheehan syndrome, we can say that postpartum. Okay, let's write it over. Postpartum, hemorrhage in anterior pituitary. As a result, the less productions of the TSH will get over here. Okay. The second type of the thing we can say in terms of the Simon syndrome. We can get it over in terms of the Simon syndrome. In this case, what type of problem we will get? Okay. Arteriovenous malformations, here we can get arteriovenous malformations. We can get also the, sometimes we can get the development of the hypertension, that can also cause this type of problem. Okay, so we can write in terms of this thing that Sheehan syndrome, if we get the problem in the anterior pituitary, in terms of the postpartum hemorrhage in the anterior pituitary, as there are less productions of the TSH will get over here. In case of the Simon syndrome, we will get the arteriovenous malformations. Okay, if we get the arteriovenous malformations, for example, the artery and the veins, they are getting malformated. For example, they are not connected in the proper way. As a result, we can see sometimes of the problems. There will be problem at the blood supply level. So we can see this type of thing over also there. Now, if we can get also different kinds of the tumors. You can get the different kinds of the tumors also that can cause this type of problem over here. Now, along except these things, you have to know the hematochromosis. Hematochromosis I explained in the, we can get where in terms of the bronze diabetes. The hematochromosis that can cause also the what? Hematochromosis. That can cause also what? The secondary hypothyroidism. Okay. And if we say that, for example, for any regions we need to do the cranial radiations. We need to do the CT, or for whatever the regions we have to use the radiations where within the cranium. At that time, if we use the cranial radiations, at that time there is chances for the development of the pituitary problem, and that can cause also the what? That can also cause secondary hypothyroidism. Now we'll talk about the clinical manifestations. What are the clinical manifestations we can get over here? Let's talk about those things. Okay. So as far as the clinical manifestations is concerned, let's show over here. for you guys. Okay, I'm just doing it over here. Okay, so see, when you are talking in terms of the clinical manifestations, what type of the clinical manifestations will get? As we know that thyroid hormone that is responsible for maintain the BMR. In these cases, we get the BMR that will be less. So whenever the BMR that will be less, there is chances for the weight gain. Not severe, will get in the modest way. Okay. The second thing is also responsible for produce the calorie. That means in terms of the calorigenesis hormone. That's why it is also known as calorie hormone. Okay. So in these cases, we'll get less calorigenesis. We'll get the less calorigenesis. Less calorigenesis. So whenever the less calorigenesis will be over here, the individuals they will be the what? They will be just cold intolerance. They will see the cold intolerance property within the individuals. So we'll get the cold intolerance. Okay. You get the cold intolerance within these patients. Okay. Now the most important problem we'll get over here, that we can get the development of the myxedema. We can get the development of the myxedema in these persons in terms of the hypothyroidism. So whenever we get the myxedema over here, what type of problem we can see? Whenever we are getting the myxedema, if we get the myxedema where? For example, within the scalp, if we see, then there is a chances for development of the alopecia, hair loss over here. We can get the, if we get the myxedema in the scalp, okay, we can get the alopecia over here. There is chances for development of the alopecia. Second thing we can get over here, if we see the myxedema, let's so over here. Okay, within the myxedema we know there is one component that is known as GAG, glycosaminoglycan. So you can get one component that is present within the that the name of the component is glycosaminoglycan, that is present where within the myxedema. Now the property of these things that can trap the water. It can trap the water. So whenever it can trap the water, if we see this GAG component where within the face, we will get what? The puffy face. The face that will be enlarged over here. So we'll get the puffy face. Okay, puffy face. Sometimes if we get this type of the component, the myxedema component, this one, where within the vocal cord, for example the voice box, we can get the hoarseness of the voice over here. In these cases, we will see whenever the female they will talk to the males, the male will think that the female is looking, talking in the way in the male talks. Okay, so in these cases, we will get changes in the voice because of the problem where we'll get the problem at the vocal cord level also. Okay, so this type of the problem, and the other problems we'll get also over here. Okay, let's talk about those things. In these cases, try to understand, it's one of the most important features we'll get over here right now. Let's make a border over here. Now in these cases, as you said, the myxedema, whenever we the myxedema, there is a chances for the development of the total peripheral resistance. So this myxedema things that can increase the total peripheral resistance. So whenever we get the total peripheral resistance, that will be increased over here. The total peripheral resistance that will be increased. Especially we will get the blood pressures that will be also increased whenever the total peripheral resistance is increased, definitely. But in these cases we will get 125, for example 100 mmHg. Now try to understand, in these cases we are getting the isolated diastolic blood pressure increased. So we are getting what? Isolated diastolic BP that will be increased over here. So we can write it over here that isolated diastolic BP that is increased. Now the isolated diastolic BP that is increased where? You can get the isolated diastolic BP that is increased in terms of we can get in terms of essential hypertension. We can get, I just said it over here right now, in terms of the hypothyroidism. Right. Okay, let's use this one. Thyroidism. We can get also in terms of the Crohn's disease. In terms of also we can get in Cushing syndrome. We can get what? The isolated diastolic, maybe that will be increased over here. Okay, only see it is normal. The systolic BP is normal, but we are getting the elevations within the diastolic BP. So we can say the isolated diastolic BP, that will be increased also over here. Now in terms of the females, we'll get the more complications. In terms of the female, we'll get the menorrhagia. We can get the galactorrhea. Why we'll talk about all these things. So in these cases, we can get, in terms of the females, we can get the menorrhagia. In terms of these things, the bleeding phase, that will long lasting. Okay, we can get also the infertility sometimes in these cases. In terms of the females, we can get this type of the problems. Now see, as far as the nervous system is concerned, what type of problem we'll get over here. Now see, in terms of the nervous system, we get the very rare cases we will get the involvement of the nervous system, but yet we can get what type of problem we will get, that is known as what? Hashimoto encephalopathy. Now as far as the nervous system is concerned, CN is concerned, what type of problem we will get? We will get the Hashimoto encephalopathy. We will get Hashimoto encephalopathy. What are the problem we'll get in these cases? In Hashimoto encephalopathy, in these cases we'll get the muscular contractions, small muscular contraction, that is known as myoclonus, just like these things. So we'll get myoclonus. We'll get the myoclonus over here. We can get also the, if we just do the EEG, electroencephalography, we will get the the slow wave. Get the slow wave over here. Okay. Along with that, we can get also, in terms of these things, we will get another thing. If we see the development of the Hashimoto encephalopathy, in these cases, if we use the anti-thyroid drugs, in these cases, that will be not responsible for these things. So if we use, instead of the anti-thyroid drugs over here, if we use the steroids, so they will be they will just give the good response in terms of the steroid. So this type of the problem we will see, if we see the problem at the CNS level, that is known as what? Hashimoto encephalopathy. In terms of the, we can get the myoclonus, we can get the slow wave if we just do the EEG, and it will be responsible. It will respond in terms of using the steroid drugs. Okay. Now let's continue. Before that, okay, let's continue. We have time? No problem. Now we'll talk about. We'll get the another problem in terms of the hypothyroidism, in terms of the clinical manifestations. Whatever the problem we'll get, for that thing, let's erase this part. See, in these cases we can get also the problem we'll get at the level of the GIT level. So whatever the problem we'll get, in terms of the GIT, you will get the constipation. We'll get the what? Constipation. Now why I am saying so that we'll get the constipations, because the myxedema component, that will decrease the GI motility. So from here, if we say that myxedema, that can decrease the GI motility. So whenever we will get this type of thing, that will develop toward the constipation. But in case of hyperthyroidism, try to understand, in case of hyperthyroidism, we'll get what? Diarrhea. That's important to know. In case of the hyperthyroidism, we'll get the diarrhea. Why we'll get diarrhea? Try to understand. In case of hyperthyroidism, so the persons, they will feel what? Hungry always. That means they will tend to eat more and more. But in case of these things, try to understand where there will be more carbohydrate, more other foods. So whenever the more carbohydrate will be there, try to understand. As a result, we will see there is a chances for the, along with that, in these cases, in the hyperthyroidism, will also get what? The GI motility, that will be also less. But in that cases, the more amount of the food is going within the GIT, and we will get the more amount of the bacterial load within the GIT. As a result, the osmotic balance will be, there will be not proper osmotic balance within the GIT. That will lead to the diarrhea. But in these cases, we will get the constipations in terms of the hypothyroidism. Okay. Now we'll talk about what are the things we can see in terms of the examinations. Okay, for that thing, if we just do the one examination, what are the findings we can get over here? Okay, let's write the names of these things. Okay, let's use this color for it. The first thing, we'll get the hung. We can write it for hung of jerk or reflex. We can. Okay. Tendon. hung up jerk tendon will get basically where? Within the Achilles tendons. Will get within the Achilles tendons. Whenever once it will be contracted, it will take too much time for the relaxations. So we will get in this cases the Achilles tendon, hang up jerk tendons. So we will get in these cases, we will get the Achilles tendon, that will take more time. Okay, we'll get slow relaxation in these cases. The relaxation phase will get the slower. So slow relaxation phase. We'll get the slow relaxation phase in these cases. Other type of the thing we can get over here, definitely whenever we're talking in terms of the what? Whenever we're talking in terms of the hypothyroidism. In this case, what do we know? Try to understand from here. Okay. What about the heart rate? What about the BP? Basically, if I say that we know that then thyroid, okay, that is a concept. The thyroid hormones, they are sensitive to what? They are sensitive to beta what? If we say in this way, that they are responsible for the sympathomimetic activity. They are the driver, we can say. They can also increase the sensitivity for the what? Beta adrenergic receptors. So when you are saying they can increase the beta adrenergic receptors over here, so whatever the problem will get in this cases. See, whenever we are talking in this way that hypothyroidism, there will be what? We'll get the bradycardia. So whenever we get the bradycardia, the heart rate that will be slower. In terms of the BP, it will be, for example, on 20/100. I already explained why we'll get on 100 over here. Okay, I have already explained. Now see, along with that, the patients, so the individuals, for example, the ladies that have come to the OPD, they can explain, they can just observe, they can just complain about their skin. They are getting the coarse skin. That means they are dry, on top of the dry skin. So if you can get over here the coarse skin. Why we can? It's the dry nature. They have used the many kinds of the drugs and many kinds of the dermatological compounds just to remove these things, but it is not getting cured. Why? In this case, if we see that whenever the individuals they are taking the different kinds of the fruits, basically if we say the fruits that contain the beta carotene, the fruits that contain the beta carotene. So whenever we get the beta carotene over here, so beta carotene, okay, that can produce the vitamin A. For that thing, we need to use what? The T4. The T4 that will help, understand the T4 that helps to convert the beta carotene into vitamin A. But in case of the hypothyroidism, what? The value for the T4, or you can say the amount of the T4 that is less. As a result, we'll see that the beta carotene that will be not able to get converted by in terms of the vitamin A. So we'll get the accumulations of the beta carotene. As a result, we'll see whatever the manifestations we'll get. We'll get the yellowish skin colorations. We'll get what? Yellowish skin. But the individual, they can ask you that means, doctor, should I have the jaundice? No, see, you don't have the jaundice. Why? Because if someone is having the jaundice, we'll have the skin yellow color. Along with that sclera, we have to check the sclera. If we, or we can say the icterus, if we get the sclera, that is not yellow, because in these cases we will not get the sclera yellow over here. Okay, so in these cases, so the sclera, that will be not yellow. So definitely the individual is not suffering from the jaundice. Okay, so this type of the problem we can say. Now we'll talk about in terms of the workup. So what are the tests and different kinds of the thyroid function test, what are the things we can do. We'll talk about all these things over here. Okay, so let's continue for those things. Okay, I need to read some part for that thing. Okay, let's read this part over here, guys. So what are the workup? I mean, in terms of the test we can do over here. Now let's talk about them. Now see, whenever we are talking in terms of the test or workup, whatever the test we can do. Okay, sorry, let's continue. So when you are talking in terms of the workup, whatever the test we can see over here, first we have to do the thyroid function test. We have to do the thyroid function test. In these cases, we have to do the test in terms of the total T3 and T4. Along with that, we have to do also it's the based on T3 free form and T4 and the free form. We can do these two tests, T3 and T4 in terms of the what? Free form. Okay. So in terms of the thyroid function test, we can use these things. Okay. Now what about the TSH? Now we'll talk about in terms of the TSH. What are the things we can do in terms of the TSH? Now if we see, In terms of the TSH, we can use in two ways, in the primary and the secondary problem. If we get the primary problem, if we get the secondary problem. If we get the primary problem over here, we can use some kinds of antibody. For example, we can use antithyroid peroxidase antibody we can use over here. Antithyroid peroxidase antibody, or you can use the antithyroglobulin antibody. You can use antithyroglobulin antibody in this case, just to check these things. And in terms of the secondary, if we suspect the secondary things, then you can just do the test for these things. You can just do the MRI of the neck. You can do the MRI of the neck in this case, just to have the confirmations in these cases. Okay. And along with that, we can also do, yes, we can do the MRI of the neck, no problem. We can just do also the head if you want, and also the head problem. But in case of the TSH test, we can do the anti-TPO, that means antithyroid peroxidase antibody. We can use the antithyroid peroxidase antibody in these cases, or you can use the antithyroid globulin antibody over here. But in case of the secondary, if we get the problem that arises at the secondary level, we can do the MRI where at the level of the head. Okay, so we can do these two things. And in terms of the thyroid function test, we have already explained over here that we can do the T3 and T4 in the free form. Okay. Now we'll talk about the other types of the test, MRI, UAG, ultrasound, whatever things we can do in these cases. Now let's talk about, in these cases, the other test we can do over here. The other workup we can do over here. We can just do the USG, ultrasound we can do, or we can do the MRI of the neck regions over here. I have already explained we can do these things. And what are the other problem we'll get over here? Whenever I try to understand from here, whenever I did explain, we can get the myxedema. So whenever we get the myxedema, there is a chances for the accumulations of the fluid in the serous cavity. So if we see over here, in terms of the myxedema, try to understand. In terms of the myxedema, we can get the accumulations of the fluid where within the serous cavity, serous body cavity, you can see over here. So in terms of these things, try to understand, we will get the accumulations of the fluid where especially in the serous cavity, that means within the pericardium, within the pleura. Now see, if we get the fluid within the pericardium, that is known as what? Pericardial effusion. So that is known as pericardial effusions. Now the pericardial effusions, for whatever the regions, for other regions we can get also the pericardial effusions. For example, certainly if we just increase the lymph drainage, or you can get the lymphadenopathy over here. As a result, we can see the accumulations of the fluid within these regions, within the pericardium. Okay, and these things that will take, for example, 10 to 12 years. Per year, if we get the accumulations of the fluid, for example, 10 to 15 ml per year, then it will take too much time to cause the pericardial effusions properly in terms of the symptoms appearing. Okay. Now see, in these cases, we are getting the pericardial effusions where we are getting the gradual accumulations of the fluid, but that thing will be not regarded as cardiac tamponade. Try to understand. These things will take too much time to appear the symptoms. But in terms of the cardiac tamponade, that is also seen for what? The pericardial effusions. But in case of the pericardial effusions, we will get what? The accumulations of the fluid that will cause the rapid contractions. That will cause the rapid contraction that will apply the pressure within the heart. Okay, that can cause the cardiac tamponade over here. But in these cases, with accumulations of the fluid, that will take too much time for the longer duration. Ultimately, we can get this type of the problem over there. So don't get confused in terms of the pericardial effusions. This for what we are getting for the myxedema development we are getting, or for the lymphadenopathy we are getting over here. That is a totally different thing. Okay. Now we'll talk about the rest parts. Okay, what are the other tests we can do in these cases? Now in these cases we'll get also that, try to understand from here, we'll get over here the lipid. We'll get the lipid, and now lipid that will be, if we just do the test of the lipid profile, we'll get the lipid that will be increased, and we'll also get the cholesterol level that will be also increased. So whenever you're getting the cholesterol level, that will be increased. So there is chances for the development of the what? Atherosclerosis. So we'll get the accelerated atherosclerosis, because the atherosclerosis that will develop very soon. So we'll get the accelerated atherosclerosis. Accelerated atherosclerosis we will get over here. Now this, if we just compare in terms of the diabetes mellitus patients, they had the atherosclerotic, definitely they had also the atherosclerosis, but the etiology was different. There we will get what? We got the triglyceride. We got the depositions of the triglyceride within the blood vessels, but we are getting the what? Lipids or the cholesterol. Especially we can say in terms of the cholesterol depositions will get, that will develop the what? Atherosclerosis over here. Okay. Now in these cases you can also do some test. You can just do the total blood count. You can just write it over here. We can do in terms of the test, we can do the total blood count, we can do the ratio for the total blood count and the MCV, mean corpuscle volume over here, we can do over here in these cases. Okay, sometimes for the diagnostic purpose. And if we just do, okay, if we just do this test, if we just get the ratio increase, definitely that can cause the macrocytic anemia. Macrocytic anemia. Now we will get the macrocytic anemia in the different conditions. For example, we can get in terms of the vitamin B12 deficiency. We can get in terms of the folic acid deficiency, vitamin 9. Okay, and we can get also whenever this ratio that will be increased for the hypothyroidism, we can get this other things. Now the last part, for the not least, we will talk about in terms of treatments. What are the treatment we can do in these cases? Okay, so let's erase some part, write down of the treatment. So I can write. Okay. Now if you want to write in terms of the treatment, try to understand. So when you are talking in terms of the treatment, so here we need to use what? The levothyroxines. Here we have to use levothyroxine. But we have to make sure that we have to use in terms of 1.6 microgram per kg body weight. Per kg body weight in these cases. And we have to also make sure that we are not increasing the dose more than 100 microgram. Because try to understand, if we increase the dose, okay, let's use the different color for it. Okay. If we, and we have to make sure that not more than 100 microgram. Because if we use, try to understand, okay, let's save it once again. If we use we have to use in terms of the hypothyroidism, so we have to use the levothyroxines, okay, and we have to use what at the rate or the dose, for the levothyroxines, the dose will be 1.6 microgram per kg of the body weight. But we have to make sure that we are not using the dose, we are not increasing the dose more than 100 microgram. Because whenever we increase the dose more than 100 microgram, at that time, as we know, there will be more oxygen consumptions over here. So more oxygen consumptions. As a result, we'll see one kind of the problem we can see over here. We can develop the angina over here. So the problem we get over here, for increasing the dose, 100 more than 100 microgram, the oxygen consumption that will be more, and that can cause the angina pectoralis over here. So we have to make sure that we have to increase the, we have to keep the dose within the normal level. And the dose, we can get the tablet in terms of the 20 microgram, 50 microgram, 100, in this way. So as per the, what will be there, so you have to use the drug in that way only. 8 or 100 microgram. Okay, so that's all for in terms of, the different kinds of the hypothyroidism, what are the drugs we can use. So let's repeat once again. Okay, these things especially. So when you are talking in terms of the treatment of the hypothyroidism, we have to use what? The levothyroxines, and we have to give the dose in terms of what? 1.6 microgram per kg of the body weight. And you have to make sure that we are not supposed to increase the dose, we are not supposed to cross the dose more than 100 microgram over here. Okay, because if we use more than 100 microgram over here, then cause the more amount of the oxygen consumptions, and whenever the more amount of the oxygen consumption will be there, definitely there is a chances for the development of the angina pectoralis. Okay, so thank you for watching, and see you in the next video soon in details about the hyperthyroidism. Okay, so if you don't like my video, please let me know also, and if you like, please do subscribe. And if you don't get any point in the videos, please let me know in the comment sections. I'll be there to help you guys. Thanks for watching. See you in the next video soon.